All right, welcome back to the podcast. I am joined today with a team of researchers, clinicians. They run the Heads Up Pennsylvania. It's like an early psychosis educational program. They also do, they work through Penn at the Early Psychosis Center. And they are coming on today to educate my audience about early psychosis treatment, psychotherapy, medication. Today we have the whole team. Monica Calkin, she is a PhD Heads Up co-director who oversees outreach, education, training at Heads Up. We also have Christian Kohler. He is a psychiatrist, co-director of Heads Up. He has participated in research on emotion processing, brain-related studies, novel treatments resulting in over 100 publications to date. We also have Dan Wolf, MD, PhD. He's another psychiatrist who oversees the telehealth program and is a practicing psychiatrist. He's a brain imager specialist in psychosis. We also have Lisa Nelson, and she is a psychologist who does recovery-oriented cognitive therapy and is supervising and seeing patients in this group. So, oh, and last of all, we have Joni Burns, nurse practitioner, psychiatric nurse practitioner who works for me, who is joining as well. So welcome, guys. Thank you for coming.
Thank you.
So
Yep,
I
thank you.
so I thought I would start out and talk a little bit, uh, just kind of ask like, what is a program for early psychosis, and how do you like what is the passion, what is the sort of the vision behind this program, and what maybe some of the just a little of the research coming out of it on what you guys have been able to do.
In other areas of the world, so in Australia and Europe, for many years, there was an emphasis on trying to engage young people who are experiencing psychosis as early as possible in care, with the recognition that the longer those symptoms go untreated, the harder it is for people to recover. So we call that the duration of untreated psychosis. So there was a tremendous amount of development in programs which provided not just medication management or therapy, but really started to provide a number of other services on an outpatient basis that could be used in combination to really make a difference in people's outcomes. And so that was so in 2015, so they were developed internationally. And then in 2015, our Congress allocated set aside funds for serious mental illness, and that led to the development of the coordinated specialty care programs in the United States. This really came on the tails of a very influential trial called the RAISE trial, which showed that coordinated specialty care was better than treatment as usual in improving outcomes, reducing symptoms, and improving overall function for the individuals who participated in that. So since 2019, so it started out, relatively small, and in 2019, as of 2019, there are coordinated specialty care programs in all 50 states. And in Pennsylvania, we currently have 17 programs for first episode psychosis, and we also have some programs that are dedicated to people with clinical high risk symptoms, which is where an individual hasn't developed a first episode of psychosis, but there are some concerning symptoms that suggest that they could. So this model is also being applied now for people in earlier stages of illness. So what we've found in Pennsylvania is that by 6 months, people do have in our programs, people do have an improvement in their clinical care, in their functioning, and a decrease in symptoms similar to what was shown in the RAISE trial. And
Awesome. That's fantastic. Yeah. This is so exciting to get you all on here and to talk about this. And one of the thoughts I had was what is the usual amount of time that it takes someone who gets psychosis to actually get into care? And then how much has your program been able to decrease that amount of time?
well, the ideal, according to the World Health the WHO standards, is 3 months of duration of untreated psychosis. No one, I don't think, has approached that. In Pennsylvania, we're at 12 months. So typically people are experiencing psychosis symptoms for as long as a year before they get into our programs. We are continuing to find ways to decrease that gap.
Okay, wow, that's great. And so what is the like average? Like if you guys if there is no program, like what you have,
Oh,
like what happens in the real world? It's I think it's around like 1 to 3 years,
In
somewhere
the
around there,
race
right?
trial, it was over 3 years.
Over 3 years, yeah.
That's
That
that was the state in the that was kind of the situation in the United States as of I think 2010 or so, when the race trial was active.
yeah, this seems to me that like we know like or maybe you guys could talk about like why is it so important to get treatment early with psychotic illness? Maybe we could start there.
well, there's huge impacts for the person's school, social life of the symptoms that they're developing. So, someone who's developing psychosis symptoms may be withdrawing from peers, becoming socially isolated, um, and um, and also, decreasing their school or work performance to the point where some people are not able to function in those environments. So, the earlier we can keep all of those things on track, by getting someone supports and wrapped around all of those different areas that are challenging for the individual, the better their outcome will be.
I think there's two things. One is a slam dunk, I think, which is that, these people are young people at critical inflection points in their kind of psychosocial development. And if you can help them be less derailed at that stage, it's just obvious that you're going to have an impact, at least on a subset in terms of the long-term outcomes. There's also, and this is an area of somewhat controversial research, the idea that psychosis is itself kind of toxic to the brain, and that the longer it goes on, the worse the long-term outcomes will be. So, while I think that remains somewhat unsettled, even if it's just the psychosocial, that just is a critical piece. And I think so to get people into treatment, both psychosocially and probably biologically, early is very important.
I think back historically, like there was this thought that people with schizophrenia often have dementia, right? So I think there's a long history of cognitive decline. And Dr. Wolf, I know you have done work in brain imaging and stuff. Is what's your sense? Do you think that there is cognitive decline in this population if they don't get treatment?
Yeah, Christian, Monica may have other views, but I think it's there's more than one thing going on here. In other words, low cognition is a premorbid risk, probably reflecting early neurodevelopment. We know that cognition further deteriorates as people develop early signs of psychosis and psychosis. And then I think some people may continue to experience deterioration, but the kind of early picture of schizophrenia as a dementia is probably not correct, meaning in most people, there's not a progressive cognitive decline. But recent research shows that there is an increased risk of actual dementia as people get older, which probably relates to various things like poor healthcare, rather than necessarily schizophrenia itself. But I don't think that's been fully worked out.
Okay, so what are what are the things that you would want providers to look for in terms of early psychosis? Like what are the symptoms you're looking for? What are the questions you're asking? Like if you could get every primary care doctor to ask these types of questions, what would you have them say?
Yeah, so we actually have developed a screening tool. It's on our HeadsUp website that we recommend. It's only a 5-item brief screener. There's several challenges we hear from primary care providers and others when they think about why, should they screen for early psychosis? Why don't people screen for early psychosis? One of the barriers is that it can be hard to tell whether or not a symptom someone's experiencing, say they're talking about hearing things, they can't quite make out what it is, but they kind of wonder if people might be trying to hurt them or harm them, but they don't know if that's true. Um, Sometimes people wonder, is this just a normal experience? Is this just an adaptive response to the circumstances that the person is in? And so we've actually age normed our screening tool that's available on our website. There's also sometimes people think about, if someone's talking about these straight odd or unusual experiences, that there may be a question of whether this is sort of due to depression the person may be experiencing, or trauma, or substances. And all of those things we do know can be comorbid with early psychosis symptoms, but we also know early psychosis symptoms can go along with those experiences as well. And so we tend to advocate for, don't try to sort it out. If someone's talking about hearing things or seeing things, or they're acting puzzled or confused, or they're talking about unusual things, or they're talking in a way that's difficult to make sense of, withdrawing from peers, those types of things, that it's important to do a screener and to see. Screening for early psychosis is not nearly as common as screening for depression or anxiety in primary care or in other settings. And we would like it to be. I think, we have an algorithm that people can ask follow-up questions to endorse responses, to try to get a sense of a little bit more about the context of the symptoms, and then a flow chart to referral to specialty care.
Okay, can we, I think it might be worth, can I just pull up that screener and then we actually look at the questions and maybe talk about it a little bit, just so it's called the Prime Screen Revised 5. Is that correct?
Yes.
And
Yes. Mhm.
people are rating this as definitely agree, somewhat agree, slightly agree, not sure, slightly disagree, somewhat disagree, definitely disagree. Okay. So question number 1 is, I think that I have felt that there are odd or unusual things going on that I can't explain. So that would be question number 1. So they're like odd or unusual things going on that I can't explain. Number 2 is, I have had the experience of doing something differently because of my superstitions. Number 3 would be, I think that I may get confused at times whether something I experience or perceive may be real or may be just part of my imagination or dreams. So kind of like people start to have issues with reality testing, right? And then 4 is, I think I might feel like my mind is playing tricks on me. And 5 is, I think that I may hear my own thoughts being said out loud. Okay. So anything you want to say about these questions?
Yeah, so we actually developed this from a 12-item screener, and we found that these 5 items predicted. So the Prime screen was developed at Yale and the Prime Clinic there, and we found that these 5 symptom questions actually predicted the total score very well. And that's why we kind of wanted to give people the briefest tool possible so they can very easily incorporate it into a very quick screen. And then on the second page of that, we do talk about how to score it. So if someone gives at least 1/6, so sort of just off the it's a very easy rule of thumb. If someone says definitely agree to at least one of those items, we would say that's concerning, or 3 or more 5, so somewhat agree to those. And then we also have a way to total the score so you can see how different a person is. Say an 11-year-old gets a total score of 20. How different, are they how different is that from other 11-year-olds in terms of 2 standard deviations away from the mean of other 11-year-olds. So it provides kind of a very quick, rapid tool to be able to gauge whether or not these are atypical responses.
Got it. Okay. So you're trying to find 2 standard deviations or more above the mean for their age group.
Exactly.
That's kind of a warning sign.
Exactly.
And so for like age 15, that would be like 15.
Mm-hmm.
So it'd be, if they have 3 somewhat agrees.
Exactly.
Okay. Got it. Yeah, that's really cool. Because then, okay, so 2 standard deviations, you're getting into that top, couple percentiles of people who are potentially having some different types of experiences. Yeah, and so like, does that predict, how well does that predict future psychotic event or a current psychotic event?
Well, we don't exactly have the answer to that specific question, but what we do know is when you do a secondary screen and then we do a more thorough, we have a specialized instruments called the Psychosis, the structured interview for psychosis risk symptoms. There's a similar, that's a tool that's widely used around the world to do follow-up questions. So you sort of think about a two-stage screening. So the prime screen will come first, do a SIPS. When we do that more structured interview, about 35% of people will develop a psychotic episode within a 5-year period on average. There's quite a range, and there's, but that's sort of on average. So that means that there's actually a greater risk of people not developing a psychotic episode. But the thing that's important to note is having these symptoms alone also are associated with poor sort of lower functioning, depression, anxiety, and so on. So these symptoms are not necessarily benign in and of themselves.
Yeah, and I just want to emphasize the goal of the prime screener is not to say, oh, you're going to develop psychosis. It's to give, say, primary care or other people out there who want to know, like, hey, is this normal or is this something we should worry about? Kind of quantitative tool that's age normed to say, hey, this person maybe should get to someone who can do a more thorough evaluation.
That's good. Okay, so in your program, you're trying to get these to family medicine doc, pediatricians, and then if they score high enough, then you're trying to get referrals to your program. Is that correct?
Yes. And I would broaden out to community mental health providers, teachers. We have an educators version. So anyone who comes in contact with the young people, in a professional capacity can use this screening tool. And there may be some, we put some decision points in our algorithm to say, what do you do? Should you watch and monitor, maybe reassess, or reassure, or yes, consider a referral to specialty care.
And then once they get referred to specialty care, who do they see in your team? How does that work?
Yeah, so HeadsUp has a central triage mechanism where people from anywhere across the state can contact us, and we'll try to connect them to the program that's closest to them, or people can contact sites directly. So on our website, we have a Find a Center page, and the centers are listed across Pennsylvania, and then the contact information is there. So either one. I do want to mention, since these programs are all over the country, we also have locators for these kinds of programs across the country as well. So there's several different locators. So if people are not in Pennsylvania, there are programs like this across the country.
And then what does it look like so now the kid is referred to you guys, and then what happens next in your program?
Yeah, so I just wanted to add that, so when people screen in through the screener and they are referred, then the programs themselves will perform another kind of screening for suitability for their programs. And the situation in Pennsylvania is that we have 17 first episode sites, so people have surpassed the threshold of psychosis on the screener, or the kind of whatever then the screener for the first episode site is. But then if people remain within that area of at-risk symptoms for development of psychosis or clinical high risk, there are only 2 programs in Pennsylvania. So the access to specialized care is a lot more limited. There's a program in Pittsburgh, and then we have a program as well. So we serve both the clinical high-risk population and the first episode population here at Penn, providing very similar services. When someone calls, again, we gather the relevant information, and then the next step is if the person is eligible. And most people, after going through the screen, then are deemed to be eligible for an evaluation. They come in typically with their parents or caregivers. We really put a high emphasis on family involvement. We're talking about young people between the ages here at Penn between 16 and let's say 25, or maybe a couple of years older than that. So as they experience these symptoms, most of them are more dependent on family support and family advocacy for treatment. And at that point, the person themselves would meet with the psychiatrist, and the family, the parents, one or both parents, would meet with a psychologist to do the collateral information about the person's development, upbringing, how did the symptoms develop, what did the family kind of see in terms of how the situation progressed to this point. And then we come together and we discuss kind of, is the person kind of willing to engage in the first episode care program, and we discuss all the services that are involved.
Okay.
And
yeah, so then it's like the conversation is moving towards like, this is kind of like the treatment package. Is that right?
yes, so this is where the coordinated specialty care comes in, which is provided by the small team of people who all work with each other on individualized care for the young person. So this is where Lisa can talk about psychotherapy. Then there's medication management. There's supported employment and education. There are peer support services, so people with lived experience who give back are very important to promote kind of understanding of illness. And then there are family support services. And so there's a whole package of 6-7 services. And again, the first episode sites receive some support through SAMHSA for those services that we cannot bill for.
Dr. Nelson, tell me about the family involvement and the recovery, like coordinated specialty care treatment model.
Okay. Yeah, so we offer recovery-oriented cognitive therapy, which is really rooted in cognitive therapy, developed by Dr. Aaron Beck. And he also was a part in the development of recovery-oriented cognitive therapy. And really there's 2 parts to it. It's really got the spirit of recovery, meaning, the goal is to help the person get to what they want to get to in their life. Whether, that is their relationships or the purpose that they want, that's the aim. But what we're really looking at in terms of what's going to help the person is what's going on with their belief system. Are there beliefs that are underlying some of the symptoms that we're seeing? And are there also beliefs that can really activate the person to really pursue those things that are meaningful in their life? So this is the treatment model that we're using, and across the different sites in Pennsylvania. And so what I have been doing at the PERC clinic, and they're going to start doing this at other clinics in Pennsylvania, is how can we adapt this model to help the families? Because the families, as Dr. Kohler was saying, are very involved. And a majority of participants are still living with their families. And that is a lot of contact time that they could really be getting help and supported, and, especially help in activating some of those beliefs that are going to get them back in their lives. And so that's, what I've been really doing is working with the families on understanding, strategies and what they can do to really help their loved ones.
Okay, just give me some like common strategies that you give families to help their loved ones. Just in case any families are listening and they can they can kind of just take it from here,
So a lot of the time the families come in, so confused, so shocked in what's going on. So a big component of the group is the support piece. Families getting together, realizing that they're not alone in this experience, that they have other people. That is one of the parts of the groups. And I want to emphasize that, because I think families having support is essential. These experiences can be so isolating for both the individual and the family. And some of the early things that I talk to family about is looking for the wins. That's one of the strategies, that sometimes we can all get trapped in these, like looking at what's going wrong for the person and their symptoms and how, it's keeping them. But if you can find those things that are going well for the person, really looking at the strengths, that's the first thing I have the families do, that's what we want to build on. That's what we want to grow. So it's kind of shifting that focus. And I start out each group asking family, give me some wins for the week. And I really see it over time in the groups, because we have 12 sessions, start to change the family's mentality and really infuse like more positivity towards like, there are some things going well. And that is in themselves, they're doing the cognitive therapy where they're looking for the good. And they're kind of changing their belief system to be more positive and more activating, because that you really want to get the families out of feeling trapped, scared, hopeless, to feeling some sense of hope. And then other things we do is, a lot of the families, when this happened, it just throws everybody off track. And so they stop doing things. Their loved one stops doing things. The family stops doing things together that they used to do. So initially, too, we do a lot of what are the things you used to do as a family? Can you start doing those to some extent again? And that entails like the families start sharing, well, we haven't gone on a even car ride together. And I'm like, get in the car and go see some trees, do some things, remind the person of who they are. And the family starts to remember, this is who we are. And everybody's kind of finding themselves again and activating those beliefs that are really going to move the person forward again, to push through some of these experiences. So that's some of the initial stuff that I think families can think about. I could also provide more examples for like how strategies we give families for like talking to someone with, some of that content that can be more delusional in nature, if that's helpful.
Yeah. Yeah. Go ahead. Yeah.
So sometimes, I think this is one of the biggest things. So the things that families really struggle with are negative symptoms, hallucinations, those perceptual experiences, and the delusional thought content when someone, is talking a lot about something like, they're really fearful of people being after them or possibly being watched, those types of things. So in recovery-oriented cognitive therapy, we're really looking at, what is going on for this person? What is the underlying belief system? And we talk about how, it sounds like the person's scared. They're feeling vulnerable, right? If they're expressing those types of beliefs about people maybe watching them or being after them. And that's something the family can work with, right? The specific content's really hard, but if you can understand that meaning underlying it, that person's saying they're afraid, that they're fearful, maybe you can do some things that help that person feel safe, help that person feel adequate, and a lot of that entails that person doing the thing again that made them feel like they were capable. And the families and I, and all together in the group, we look for that thing for the person so that they can start doing it more and the family can support them or do it with them. So that's kind of an example.
Yeah. Getting them to do the things that made them feel capable before the psychotic stuff started, right? And then moving the families from a place of trapped, scared, hopeless into a place of like, there's some things we can do. There's some progress we can make. We can move forward. So it gets that family system kind of moving in the
we should
right
also
direction.
mention, we should mention having to deal with that. A lot of families feel guilt about their adolescent or young adult experiencing psychosis, and parents then look back and blame themselves for what could they have done to have contributed to that, or what did they miss so that the person didn't come to treatment earlier. And this is where the interaction with other parents is really important, so that they learn that this is an exceptional kind of event that happens that can't be predicted, because the psychosis is, you could call it a random occurrence. It's not all that frequent within society, but it makes such a great impact on family units, so that families know that they are not to blame, that they then can again focus on positivity and a way forward.
What is it? Schizophrenia occurs 1% in all cultures, all populations across the world. Dr. Nelson, anything that you say to help families reduce their guilt?
I think, knowing they're not alone, but I really, the most convincing for families is really when they hear from other families. I see such a light go on for them when they hear someone talking and they know that experience to some extent. Never two experiences are the same, but the similarities are there. And knowing that this parent is so involved in trying to, and it's not like something that they necessarily like they did wrong, that they are a good parent. They were doing what they could do. When I work with the parents, they're always constantly asking me for things to do. They want to help. They want to be involved. And so it really is important for families to have some ideas or some strategies so they can be kind of a part of that process, because the research shows that family involvement really helps people stay engaged in treatment. It's really important for that. In terms of like the rate of relapse, that's reduced if families involved. So having this network, because the hardest part of, recovery is if, you feel alone in it. But if you have a network, you feel supported, you have that family network, and then hopefully your clinic can also provide you with that support system. I think that is one special thing about coordinated specialty care, is it does create this like network for people in terms of like the family system, but also hopefully peer and, having someone to support you around education and those types of things. So I think the biggest thing I say for families is to reach out and get support.
Let's talk a little bit, Dr. Christian Koholer, tell me a little bit about the psychopharmacology considerations in early psychosis. What are the things what are the perspectives that you have? What works the best from what you've seen over the years?
So we view medication treatment as an important part of coordinated specialty care, but also one that where we have to pay a lot of attention to with respect to kind of which medications are indicated and how does the person agree to take medications, how sensitive are they to medication side effects. In early psychosis, it is common for people to experience, other than psychosis, a lot of anxiety, depression, trouble with sleep at night. So it's not uncommon for people to present already being on, let's say, antidepressant medications, anti-anxiety medications, in terms of coming to an agreement about taking an antipsychotic, because in some respects, the health literacy is fairly high in young people when we recommend medications to them. Then the next thing they will do is they will look them up and read about them, and it's important that they understand what these medications do. So we want to be we want to focus really on target symptoms that young people would agree to, that they bother them, that they need to be treated, such as hearing voices, having frightening thoughts, feeling unsafe. So it's important to focus on target symptoms rather than labeling the condition as anything more than even than psychosis symptoms. And we really use family members as advocates for medication treatment. Then with medication treatment, it's important for young people to be started on really on a low dose of an antipsychotic medication, and advance that gradually, being very mindful that on the positive side, people who have never been exposed to an antipsychotic before for the treatment of psychosis, they are more sensitive and they respond better to medications. But on the negative side is that they're also more sensitive to side effects. And if we treat people with standard doses of medications too quickly, then the side effects will be more prominent and people will then stop medication. And that in itself then can start the process of people being more opposed to taking medication or just flat out refusing treatment. So I think up front, it's just very important to be sensitive about negotiating with the person and their family which medication to use, and then to move forward.
So I had Dr. John Kane on the podcast. I think you guys reached out maybe after listening to that episode, and we talked about long-acting injectables, we talked about clozapine, and I'm curious what role clozapine or long-acting injectables have in your sort of approach.
So to start with long-acting injectables, I think as was mentioned in the John Kane podcast, in the past, long-acting injectables were viewed as treatment for people with chronic serious mental illness, where the symptoms could be stabilized, but where recovery was no longer possible. That included the time period until second-generation antipsychotics came on the market, which was a little more than 15 years ago. And then with the advent of second-generation antipsychotics, which are a lot more tolerable, the field has commonly moved towards using long-acting injectables much earlier in the illness. We have to consider that about between 25 and let's say 40–50% of people experience difficulties with treatment adherence, with medication adherence. And the long-acting injectables can really help a person who would be willing to take medications, but for different reasons, be that poor memory, having trouble with organization, or feeling 3 out of 7 days that they need medication and 4 out of 7 days that they don't need medication, then become non-adherent to antipsychotic treatment and therefore don't benefit. So I think that we try to capture that group of people who are willing to be treated, but have trouble adhering to medication much earlier with the long-acting injectable medications. And in general, they are just underutilized in the United States, and a lot of work needs to be done to make them available to more people, but in a way that is based on a mutual agreement and not a coercive way. Then the issue with clozaril is that clozaril also is widely underprescribed in the United States, much more than in really the remainder of the world, surprisingly, and it has to do a lot with the providers not feeling comfortable to prescribe the medication, feeling that clozaril poses a burden on the prescriber because of the frequent blood checks, but also because of the risks that are associated, that are relatively small, but that are associated with clozaril, such as neutropenia and some other side effects. So clozaril really should be used after a person fails 2 standard trials of antipsychotic medications, and we are very far away from the point where the field would widely accept that for different reasons.
We're not there yet.
No.
What do you think it would take to get there? I mean, like what efforts can we make other than having a podcast like this and encouraging people to use clozapine if they failed to trials of antipsychotics, right?
Yes, I think it's really us prescribers who are the target group to change the representation of the prescription rates of clozaril within the psychosis population.
I know my personal issue. I have 2 patients that would benefit, I think, right now from clozapine. One of them doesn't want to see me at all, doesn't believe he has schizophrenia, has no insight into his disease, will attack his parents even. The only hope for him is to almost like hospitalize him once a month and get an injection. I don't know if you have any other insight into this, what to do with this particular patient. And then maybe I'll tell you the second one. I'm going to change a couple details, of course, and leave things vague on purpose. But yeah, the second one, there's no insight into disease. He gets injection once a month, but it's not enough. He's still, his thought process is not kind of glued back together. He's still stuck, not able to move forward in his life. So I'd be curious from maybe Dr. Nelson's perspective on what she would do psychotherapy wise, but also Dr. Wolf and Dr. Kohler, like what you guys would recommend as well.
Yeah, I'll hand it to others, but let me just put in a pitch for coordinated specialty care. I mean, we're trying to get that to people in the first 2 years, but it's just better care. I don't actually work in coordinated specialty care. I mean, I collaborate with these folks, but I work as an outpatient psychopharmacologist. And the team approach, the wraparound services in coordinated specialty care should be standard of care for everyone with schizophrenia, not just for the first 2 years. So some of these medication difficulties are almost impossible to grapple with when you're seeing someone 30 minutes, once a month. It's very hard to build that alliance, and you don't have those other supports to address what's more important to them. If they don't think medication is the answer, that takes a long time to increase that insight and build that trust. And having a team of people who are not just showing up saying, hey, take this medicine or else, is really critical to the medication piece. So some people do very well in a standard outpatient practice, but there's a lot of people that just aren't sufficiently effectively reached by it. So I'll hand it over to the folks who are more on the ground in that.
Well, Dr. Pudi, you mentioned insight, which is a huge variable in the population that we are treating, and again, getting back to what I said before, that early on we are working on the person having insight that there are symptoms that need to be treated, and later on trying to pull this together about explaining the person kind of what does this mean clinically. Some people can come off medications. Some people need to have long-term treatment. Now, insight is interesting because insight can be gained early on in my opinion, in the let's say the illness of schizophrenia. It is much harder to gain insight later on. So people who have low insight or poor insight will stick with that schema, and obviously they remain undertreated, and that just reinforces poor insight and that they won't respond to treatment. It's a very vexing situation, and I think that in the United States, you're talking about this kind of this gray area of kind of a person's to have to respect a person's willingness to come to treatment and the autonomy to refuse treatment, versus kind of what can we propose, or even some more kind of supportive, or let's say coercive methods, such as mandated outpatient treatment to keep people in treatment. But when we talk about long-acting injectables and clozaril, I think the low-hanging fruit is really the population of people between those who just respond very well to treatment and those on the other end who respond poorly to treatment. There's a lot of work to be done in that middle section to change the overall outcome of schizophrenia spectrum disorders or the psychotic illness.
Okay. So far I have coordinated specialty care, team approach, that if they can gain insight early, that usually stays with them. If they don't gain insight early, they've been psychotic ill for years, it's going to be harder to gain insight. Okay, so what exactly, yeah, Dr. Nelson, any sort of pearls and wisdom on what to do when someone has low insight? If, let's say, you're coming in with your coordinated specialty care, like what are you doing to help them in that journey?
Well, one of the things that I think about with insight is the person's also reasons. Like there might be reasons that you don't want to identify with a certain diagnosis, like schizophrenia has a huge stigma. And there can be some things about, the person also might not want to talk about their symptoms because the symptoms, at some point relate to some sort of trauma associated with their early episode. Thinking and talking about these things is aversive for people. So that's something that, I keep in mind in terms of, are there any ins that the person can talk about these types of things? But I guess I would also say that something that I tell families is that, recovery is an active process. It's not a passive process. Waiting at home for the medication to kick in doesn't always work for people. Sometimes you really have to go out there and start doing things again to get that organization and that structure back in your mind. And sometimes we really do hear families or, loved ones saying like, well, when are I'll do something when the medications start to work. And those people can end up sitting around for a long time because there is a psychological component to this that, in Dr. Beck's early research looking at this with Dr. Paul Grant, is that people have these, they can have the negative symptoms, but they can also have negative beliefs associated with those. And those have been found to be these defeatist beliefs that people form after an episode that like, they're only going to fail if they try, or that people don't actually really like being around them, and these are really what can get a person stuck, and they can stick around unless the person starts doing things again. And, if you have those belief systems, like, what's the point? You're not going to put forth the effort. And then you can't really see your capability, right? It's really hard to get a gauge of how well the person is thinking and doing. And so, when you're thinking about a person and they seem really stuck, I would really look at what are they doing in their day? What is their schedule like? When they wake up on Monday, what time is it? What do they do? How do they get their day started, the structure that they have? And that is a lot of work that I do with families is I'm like, give me their calendar, tell me what they're doing, that kind of thing.
Love it. There's some really good stuff there. Of course, this is such a vexing, difficult situation to kind of look at like the potential reasons they don't want the diagnosis of schizophrenia, maybe reason like what it means to take medications, maybe past traumas related to taking medications, being forced to take medications, and kind of breaking down like what kind of beliefs surround what's keeping them from moving forward. What is the point? The defeatist beliefs. I think that's all really helpful. Yeah. Any sort of other thoughts jumping in to anyone else's mind as Dr. Nelson talks about this?
From a broad standpoint, like really enjoyed looking into your work on the nuanced approach, like going beyond the first episode and looking at that as a treatment point and walking it back to where you identify clinical high risk and attenuated psychosis. I'm wondering if it would be possible just to provide maybe more of a definition of what you're describing or thinking of clinical high risk. So providers out there in the trenches, they see a patient in front of them, they do the screening form and say, yes, this is what this is.
Generally in the United States, we're looking at what we call subthreshold or attenuated versions of threshold symptoms. So threshold symptoms being hallucinations where the person has a full-on sensory perception with 100% sense of reality, where they're hearing things that aren't there, as hearing a voice as clearly as you hear me now. In the subthreshold or attenuated version of that, a person may not have 100% conviction. They may they may hear things. They may mishear things, so they might, there's a fan going, and they hear whispers coming out of the fan. There is a stimulus, the fan, but they're mishearing them. So that's an attenuated version of the more threshold form of hallucination. Similarly, for delusions, delusions are false beliefs that a person holds with 100% conviction. So if I believe that the FBI is out to get me, they're trying to hurt me or harm me in some way, and I believe that with 100% conviction, at least at some point in time, that's a threshold delusion. A subthreshold version of that might be, I kind of wonder, I see people out there. Could that be the FBI? No, maybe not. I'm not sure. And so there's a less conviction in that belief. It's not held with the same level of severity or intensity as what a person experiencing a threshold symptom would be. So in that screening tool, all of those are actually pitched more towards the sub-threshold level, which means anyone saying definitely agree to any one of those might have anywhere from sub-threshold on up to threshold. And one of the things we do in the other pages on that is to actually provide some follow-up questions that can be asked to get at sort of the threshold versus sub-threshold level of intensity for those symptoms.
Yeah. Any follow-up questions on that, Dr. Burns?
No, that I think that was really helpful for someone who may not be reading the write-up, which right now it looks fantastic in its draft form. And just hearing and listening to the episode just gives, I think, highlights how the work of this group really breaks this down into recognizing that we're not waiting for the first episode. We're really trying to see these distinguishing factors before we get to that flare.
Exactly. And then Dr. Wolf, I don't know if you wanted to say something about that as far as Pro Network and AMP schizophrenia.
I think time is short, so we can make a promise for the future. And most of these are research studies that don't have results yet. So, we can come back another time. But I think broadly, there are two massive efforts. One is getting what we know works better and well to as many people as possible. And there are huge barriers to that, and doing the research to prove it works better so that insurance, needs to pay for it. That's one goal. But then the best care we have right now is not good enough. So the other massive effort we have, and that relates to the LAIs and your patients on clozapine, even our best treatments don't work well for a lot of people. So, it's exciting times on the research front in terms of bringing together many academic centers into networks to get the necessary expertise and sample size to start to combine clinical assessments with biological assessments, genetics, brain imaging, structure and function, hormones, inflammatory biomarkers, facial and speech patterns, digital phenotyping. I know you talked about with John Kane's group, smartphone data, and to use that to be able to better understand and predict what's going to happen to people, and be able to use that to be able to test new treatments to hopefully eventually prevent, but also treat and change trajectories. So, our group is also part of ongoing NIH-funded research efforts to develop biomarkers to kind of figure out who will respond best to what treatment and predict better who's going to have which outcomes, which is really critical for progress. And also the EpiNet. So these will give you information to put on your website. EpiNet project to develop kind of learning health systems so that as these coordinated specialty care programs and things are trying things out, the results are being aggregated and used in kind of closer to real time to learn how to improve care at a systems level. So the combination of bringing biology into this and bringing kind of modern technology into systems level care, this is a promise for the future, but it's an exciting one, I think.
Okay, one other thing we haven't really talked about is the impact of substances on the development of psychosis. I've done a prior episode showing the link that we're seeing with THC and psychosis. The higher potency THC content has led to increased risk of psychosis. Any thoughts on this? Any work that you guys are doing on this as you in your program? Like, is this part of the package of what people get, like abstinence from marijuana, or talking about the risk factor of marijuana, or
yeah, maybe I can kind of talk about the more general approach of the first episode sites, and then Monica talk about more specific interventions. But yes, it's a huge problem in the first episode population that between 30 and 50% of people use marijuana, cannabis, before the onset of the first episode of psychosis. And you already mentioned kind of that there are different models about how cannabis affects psychosis and brings out psychosis. But fact is, it's very problematic when a person continues to use cannabis products because it is associated with kind of worse treatment response, not just pharmacologically, but also the person being able to engage in treatment. And the programs really try to work with young people using kind of, first of all, education. Marijuana, cannabis is widely disseminated within the population, and with medical marijuana cards that everyone can get for treatment of anxiety and the like, and the acceptance in especially that age group between 15 and 30. People don't understand that in a person who has experienced psychosis, the use of marijuana is problematic, and that they are kind of that they are part of an unfortunately select group of people who just should not be using marijuana. And that kind of bringing that information across is challenging, because there's peer pressure, and then people view that they treat themselves, they treat their anxiety, their sleep problems, but at the expense of worsening psychosis symptoms, or not being able to stick with the treatment program. So I think the first episode programs do a fairly good job up front with respect to education. Also, that would involve the family unit. And what we see is the use of marijuana to drop within the first 6 months or so by about half. But then the issue is kind of how do we then address the continued use of marijuana? And so just in terms of a general approach, the first episode cites we are not substance use treatment programs. So at some point we have to make the decision, should we refer a person to an intensive outpatient program for substance use? And fortunately, there's more kind of acceptance that that marijuana use can be a problem that needs to be treated. I remember 10, 15 years ago when we tried to refer someone for what we called cannabis dependence, the programs just wouldn't take them, because at that time kind of the agreement was, well, that's just not a problem that substance use treatment programs treat. So then, Monica, maybe you could talk a little about the motivational interviewing, that project that's part of our EpiNet.
Yeah. So we're part of the Connection Learning Healthcare System Early Psychosis Intervention Network that Dr. Wolf was talking about. So that's a collaboration between Pennsylvania and Maryland, and a learning joined in one hub of EpiNet. And so uniting our programs across both states. And what Melanie Bennett there at the University of Maryland has developed is working to develop is an adaptation of the teen marijuana checkup, which is a motivational interviewing strategy that was developed for a broader audience, but really looking to tailor that to the experiences of people experiencing a first episode of psychosis. And so a lot of it centers around traditional motivational interviewing approaches. You're kind of assessing where the person is. You're starting to understand their motivations and the reasons they use cannabis, meet them where they are, walking into change, sort of starting to identify ways, change talk. So thinking about, what the person themselves might want to see changed or different in their life if they're not using cannabis, and then moving into sort of action. But it really focuses on meeting the person where they are and kind of going from there in terms of reducing or eliminating cannabis use. So there's a pilot study. She's adapted it. Now she's testing it. So we'll see how that
Great.
works.
Awesome.
And I'll just add a again, pointing the future wrinkle. I mean, I think things are going to get worse on this front because so decriminalization likely a good thing, but switching from decriminalization to let's fund our educational system on tax dollars derived from getting as many people to use marijuana as possible. Anyway, we're going to see increases in psychosis related to cannabis, and it's, I think, a difficult thing to treat.
Wait, say that again. We're gonna fund this?
Fun.
The
Well,
fund the use?
I'm just saying I think there's a reasonable middle ground. I'm not a policy person, so these are just my opinions, but there's a middle ground between, throwing people in prison for smoking marijuana and setting up big businesses with ads to sell marijuana to
Oh,
as many people as high at a higher potency as
okay.
possible.
I
So, we see the people who suffer from the, increasing use of cannabis, and there's going to be increasing prevalence of psychosis. And I don't see that turning around in the near term. So to the extent that there's any silver lining, it's that, from a biological perspective, it's very interesting that cannabis seems to play a causal role in precipitating psychosis. And there's a lot of interesting biology in the brain. Cannabis works by doing things in your brain, and there's plasticity mechanisms it's affecting during adolescent development that likely produce this risk. So there's going to be a lot of research into how cannabis increases psychosis, and, potentially a silver lining, which I wish we didn't have, the cloud, is to, understand those mechanisms and use those to actually do a better job of, reversing those processes, not just for people who are using cannabis, but for everyone who's developing psychosis. There are probably broadly relevant neurobiological mechanisms at play that cannabis is impacting.
And adding to the public health concern, just anecdotally, every audience, I give a lot of presentations, lots of talks. I talk to parents, educators, students themselves, young people. They are shocked to find out there's any association between cannabis use and mental health, let alone psychosis. So I think that's not coming out in the public messaging. And there's some cultures and subcultures where cannabis use is just so normalized that there's no messaging about the adverse mental health effects. So I agree with Dr. Wolf. Big problem.
Yeah, I wish they took the dollars that they spend locking up people who smoke cannabis and turned all those dollars into treatment, like your program and addiction centers. And, that would be my dream. Is it going to happen? Probably not, but
that's what I call the reasonable middle ground. It would be nice.
Yeah, they should tax cannabis to fund psychosis treatment centers, stuff like that.
Exactly.
Okay, so I want to make sure like we've covered most of the bases. One of the things that's kind of like it's still like I haven't really figured out is so there's some like lighter psychotic symptoms that you're screening for that are positive. Like, okay, the FBI isn't out chasing me, but was there FBI? Like, was there someone outside? It's a little bit more subtle. Are you following those people? Are you just starting treatment? Are you starting antipsychotics? Like, what is the standard care for the more subtle psychotic symptoms?
So the standard care in our program is after discussion, we have had this multi-tier approach where in people who, and it's of course flexible, but in people who have very soft psychosis symptoms, we offer education about that this is a clinical high risk state, but always with the information, as Monica stated, that most people who are identified as clinical high risk will actually not experience psychosis over a period of, let's say, 2 to 5 years. But people will have other symptoms. They will have anxiety, mood problems, and they will benefit from engaging in treatment, be that psychotherapy, medication management. We tend not to use antipsychotics for people at clinical high risk, unless the symptoms are so severe that it pretty much predicts the conversion. And I mean, that is very difficult. Conversion can happen very gradually over time. Conversion can happen suddenly. So, but I think as a field, we have come to realize that antipsychotic medications play very limited or no role in the population of people with clinical high risks, but antidepressants certainly can. But so we offer similar treatments, but perhaps at a reduced frequency, and really what the person is agreeable with. And then we try to follow people over time, make sure, I think one advantage is that they have been engaged with the location of treatment. And even if they don't come there for several months, they know that if things get worse, that this is a place where they can return to for further evaluation and care. And to try to then grab people earlier if they convert to having actual psychosis. My understanding is that even in settings that have universal healthcare, such as United Kingdom, that most people in first episode programs are not identified as clinical high risk before. So I think theoretically a lot of work would need to be done there, but I think it's also illustrated that in Pennsylvania there are 2 clinical high risk programs and there are 17 first episode programs. So in some respects, it's a lot easier to, clinically speaking, to kind of focus on the person who has experienced psychosis and is past the threshold, rather than the population of people who have high-risk symptoms.
Okay. Thank you for that. Yeah. Okay. Dr. Calkins, any final pearls that you would give providers who are treating first break psychosis, who are out there in the, maybe imagine a nurse practitioner in rural, America, and they're in the trenches. Any pearls that you would give? And maybe I'll ask all of you guys this same question.
Well, one thing we haven't really spent much time talking about today, but I think is really important, is that, schizophrenia and psychotic disorders are highly stigmatized. They're the most stigmatized disorders. And most of what people learn about psychosis disorders comes from the media. So one thing I would say is I think everyone should educate themselves about what those stereotypes are about. SMI Advisor has some really great myth-busting things. It's because part of what we see is that a lot of the stigma is internalized, not by just individuals and their families, but also by care providers who may think about schizophrenia and psychotic disorders as chronic, debilitating disorders that a person can never recover from, for example. And so the message that I would have is that we know that's not true, that people who have psychotic disorders can recover, go back to work, go back to school, have meaningful social relationships. That varies, according to the individuals. For some people, there's many different courses that people can have, but I think those unfortunate portrayals, mostly in the media, have really entrenched stereotypes and in many people, across our society. And it's super important to make sure that we're aware of those and don't use those to guide our thinking about working with any given individual.
Great. Thank you. Thank you, Monica. That's good. Dr. Wolf, any
just two final points. One is for individuals and families, getting into treatment and staying with treatment. It's not perfect and it can be hard to access, but that's the most important thing, I think. And then on the research side, research is slower than we would like, but there are even better treatments that are being developed and will be developed. And so, we live in an era where there's some skepticism about science, but the science is really critical to figure out what works and find things that work better. And so encourage people to be supportive, participate in those research efforts, but also just be supportive of efforts to have public support and funding for research that's going to bring better treatments down the pike in the future.
I wanted to follow up on what Monica had talked about in that to decrease stigma and increase health literacy, that really the increased involvement of people with lived experience is just very important, both on the level of the treatment programs to kind of serve as a connector between the clinician team and the person receiving care, but also having more visibility within the population at large, to make people understand that people who have had schizophrenia spectrum disorder or a psychotic illness can fully recover and can be functional in society, so that then would decrease the stigma and the negative stereotypes.
So, Dr. Kohler, do you recommend that I have patients that I've treated that are now stable talk to my patients that are unstable? Is that ethically okay for me to do? And then do you think it's ethical for me to have a patient of mine who's stable on my podcast to talk about their journey?
I mean, I was thinking about putting in a plug for that, having a podcast where you invite people with lived experience to talk about their journey and the work that needs to be done, both on the ground with respect to treatment, but also within communities and society at large. I think that would be hugely helpful.
Well, maybe not your patients though, just someone else's patients.
No, I'm open to your considerations here. I've thought about this. I get emails from patients who want to come on my podcast who are not my patients. Some of them seem very unstable. And some of them have not come out publicly, and I don't think they fully realize if, there still is stigma against mental health, like, will that hurt them to come out publicly? So I think I'm always sensitive to that factor. Interestingly, I had one patient come on with factitious disorder who had, who came on, and we changed her voice. And, we offer CME for this, and I cannot track her down anymore. I think she went completely off the map, not wanting to be connected any longer to any emails or anything, right? Go on with her life, and she had recovered from a really bad case of factitious disorder. So yeah, I sometimes wonder how to do this in not a way that is salacious, like some of the, like you see some TV shows where they bring on someone who's obviously still very ill, or it just is an awful thing. Or
so I have a recommendation on that. There's a group of certified peer specialists. Those are people who have lived experience, who've gone on to become certified peer specialists, and they work in programs. They are part of the coordinated specialty care teams. So Elisa supervises our peers, but they're stable, have had training in sort of how to disclose and not disclose, and appropriate ways to talk about their experiences and so on. So that may be something to consider.
okay. Dr. Nelson, any final sort of thoughts?
I guess one thing that I think is important to say is that, for a lot of people, the onset can happen very quickly and the recovery can take a long time. And one of the things that I hear from people that I work with, but also families, is like, when are they going to feel better? And even that term to me can be really vague. Feel better. What does that look like? What would they be doing? What would they be saying? How would they be acting? But I think it's important for people to know that it can take time. And just because it doesn't happen in the way that you want it to, or we're hoping it would, doesn't mean it can't. You know, and I think it's important for people to know that, who are having these experiences, families to know that, and providers, because sometimes people can say, well, this is who they are now. And, you know, it can take years for the person to really get back to the things that they were doing before, but it is really possible. And that kind of connects to that stigma piece, that a lot of people are so fearful that this is their new normal, when there are things that that person can continue to have that progress over years, and get back to doing things that, you know, are really meaningful to them, or having some relationships that are really important. So I just want to kind of emphasize that hope piece is really important, because then people stick with treatment.
Excellent. Dr. Burns, any final thoughts, reflections, things that were helpful?
Well, no, I really appreciate you all coming on to speak about this. Your work is incredible, and I encourage other providers, once they hear this episode, to take a look at the website, take a look at the resources, because the pearls that we're talking about are embedded in there. There's you can share this information with family members to provide them additional support. Just really incredible resources, and y'all have really put a lot of hard work into this and are helping so many people.
Yeah. And I would echo that. This is I was thinking about how much of a pleasure this is to be able to come on and to interact with a team that is doing what I would consider the best type of, you know, pro-social activity you could possibly do in a community. You know, I think our culture should be graded on how we take care of the people who are at their lowest point in their life, you know, who are having the most struggles. And viscerally for me, when I hear this, I imagine, you know, if one patient is helped in this way, just one, maybe they're not homeless in 3 or 5 years. Maybe their family is not chronically stressed in 3 to 5 years from them being homeless. Maybe they are not using drugs or kind of get pulled into other things like prostitution or something like that, which I've seen happen. So when I see a program like this and I think, you know, okay, here's some smart people who are really thinking through how to both educate, but also do the research, also empower professionals to do good care. So it's a pleasure having you guys on, and thank you for reaching out to me, and thank you for the write-up. There's a write-up that goes with this. It'll be on psychiatrypodcast.com. It'll have all the links to everything that we've talked about. It's currently at 16 pages. We'll see how it gets expanded in the next week or two before we post. All right. Thank you guys, and we'll leave it there.
Yeah.
Thank you so much. Appreciate
Thanks
it.
so much. It's been great.
Thanks.